Orbit we fear because we have not studied. But orbit is probably one of the smallest topics that I can teach you in ophthalmology. Yes? In orbit, as you can see on the screen, we have to read basically two things. One is anatomy. And after we are knowing the anatomy, we need to read one major pathology, that is proptosis. Now, I'm not going to duplicate your knowledge. I'm not going to waste time in the ophthalmology lecture and teach you anatomy here. In anatomy of the orbit, we already know superior orbital fissure, inferior orbital fissure, optic canal, and all those things. We have read it in anatomy. So I'm not going to duplicate it. We just need to know the structures and blah, blah, blah. So straight away, what I will be teaching you here is the important topic which usually confuses students is proptosis. Okay? So let's begin with what is proptosis. Proptosis is basically this. If you look at my eyes, what is occurring? That due to some pathology, my eyeballs are protruding out. Yes? So protrusion of the eyeballs. Basically like a cartoon character, if you've seen Tom and Jerry or something, whenever they are surprised, their eyeballs pop out of the socket. But what is protrusion of the eyeballs? How do we measure it? Protrusion of the eyeballs is measured as distance from lateral orbital rim. So everybody, this is my lateral orbital rim. We have to measure the distance between the lateral orbital rim and the anterior most part of the eye. This is done using, you will be able to see the image, everybody. This is done using this instrument which is called as Hertel's exophthalmometer. Proptosis is also known as exophthalmos whenever you want to refer it in terms of thyroid. So that is where the name has been made famous, exophthalmometer. If the protrusion is greater than 21 mm, we call it a case of proptosis. Are we clear about this much, everybody? Yes? Now, once we know what is proptosis, we need to know the important questions as far as the causes, etc. of proptosis are concerned. Let's see, everybody. So, the proptosis in a lot of cases is intermittent. This is one specific subset of proptosis. Intermittent proptosis. That means the proptosis will sometimes be seen, sometimes not be seen. Yes? So what are the causes of intermittent proptosis? If the proptosis increases with upper respiratory tract infections, URTIs, then the cause is said to be orbital lymphangiomas. Am I clear, everybody? Done? No confusion? Secondly, if the proptosis increases on crying, then the usual cause that we say is capillary hemangiomas. Obviously, in children we are talking about here. Or the cause can be encephalocele in infants. Okay, no confusion about this. Then, moving on to another such cause of intermittent proptosis based on a specific factor. If the proptosis increases on bending forward, basically झुकने पर, or on Valsalva maneuver, which all of us must have tried doing successfully or unsuccessfully as soon as we got to know about it in third year in ENT, guys. Yes? Then the answer is something on which sometimes questions are asked, that is orbital varices. Now, because questions are asked on orbital varices, lot of times only this line is sufficient. But if still you want to know more, there are certain 3 or 4 points that you must be able to remember about orbital varices. First point, when you are doing MRI or CT scan, it will show phleobits. Okay, no confusion about this. When you palpate and touch, it has a consistency of bag of worms. Okay, then third point that you need to remember, it is always unilateral and the age group affected is children. So about orbital varices, if you know this much, I don't think you should have any problem. Obviously, along with the main point that we are talking about intermittent proptosis here. Okay, now moving on. After intermittent proptosis, there is a specific variety of proptosis that we call as pulsatile proptosis. I hope you understand from the name pulsatile. Okay, in, out, in, out. Pulsatile proptosis can have two causes. Number one, if there is a orbital roof fracture, as in neurofibromatosis type 1, or the more common, more important cause, what we call as CCF, keratico-cavernous fistula. Okay, everybody, CCF, keratico-cavernous fistula. Now, please remember, keratico-cavernous fistula is usually in 75% cases due to trauma, whereas in 25% cases, it can be a spontaneous connection. But if it is spontaneous, it is only seen in adults. It can never be seen in children per se. Now, along with this, what you should be able to remember about keratico-cavernous fistula is that it is bilateral but starts unilaterally. So it will occur on one side first and then the proptosis and then the condition will make it bilateral. But almost always it is bilateral in every case. Also, along with this, the patient always complains of severe ipsilateral headache, plus the patient has third, fourth and sixth cranial nerve palsy. Why is it important, everybody? What is the nerve supply of the extraocular muscles? SO4, LR6, O3. That means there will be complete ophthalmoplegia. Ophthalmoplegia means restriction of ocular movement. Okay, everybody? So third, fourth, sixth, all the three nerves are involved in this case and you end up with complete ophthalmoplegia. So this is basically your keratico-cavernous fistula. The main point being pulsatile proptosis and bilaterality, along with that other clinical features to go. Done, everybody? So intermittent proptosis and pulsatile proptosis. Now, apart from this, everybody, the important question comes on inflammatory causes of proptosis. There are two main inflammatory causes of proptosis. One being cavernous sinus thrombosis and the other being orbital apex syndrome. This is usually where students get a lot of questions wrong. But you should not. Why you should not? If you know your anatomy. Now, I ask you, which nerves pass through the cavernous sinus? If you know this, you are set and you are able to answer this. Third nerve? Yes. Fourth nerve? Yes. Sixth nerve? Yes. Plus what passes, everybody, is V1. That is the first branch of the fifth nerve, which I am writing simply as ophthalmic nerve. Plus V2. That is the second branch of the fifth nerve. That is the maxillary nerve. Okay. Now what passes through the orbital apex? Orbital apex is made up of two structures, I can say. One is the optic canal and the other is the superior orbital fissure. Through the optic canal passes my which nerve? Second nerve. Through superior orbital fissure, 3, 4, 6 plus the first branch of fifth. So these are the nerves which pass through the cavernous sinus and through the orbital apex syndrome. Clear? So now let's focus. Cavernous sinus thrombosis, what will be the clinical feature? Third, fourth and sixth nerve will be affected. That means there will be ophthalmoplegia. But this ophthalmoplegia does not occur together. This is sequential. Sequential means, first of all, one nerve, one movement, then the other movements, the other nerves. So the question comes, which is the first nerve, the earliest nerve to be affected? So the earliest nerve to be affected in cavernous sinus thrombosis is always sixth nerve, followed by third nerve, then at last followed by fourth nerve. Okay? So we have a question here, number 1, that sixth nerve is the earliest affected. Okay? There will be ophthalmoplegia, but sequential. Now let's see, everybody. The first branch of the fifth nerve is getting affected. That is the ophthalmic nerve. Now if we know the nerve supply of the cornea, everybody, what is the nerve supply of the cornea? Trigeminal branch, ophthalmic branch, nasociliary. So because ophthalmic nerve is getting paralyzed, everybody, what will occur, everybody? The cornea will lose its nerve supply. So the patient will present with corneal anesthesia. Am I clear to everybody? No confusion about this? Now, based on this, let's have a look at orbital apex syndrome. Second nerve is gone. If the second nerve is gone, the vision is lost. Third, fourth, sixth gone. So there has to be ophthalmoplegia. But this is always concurrent. Concurrent means it will occur together. There is no sequence in this. And then if the first branch of fifth nerve is gone, again there is corneal anesthesia. Am I clear, everybody? There is no confusion about this. Yes? So based on just this much, in a question you should be able to differentiate between cavernous sinus thrombosis and orbital apex syndrome. But if still you are not able to differentiate, then let's see the other points of difference, everybody. Cavernous sinus syndrome is almost always bilateral. It starts unilaterally, but then it becomes bilateral. But orbital apex syndrome will always be unilateral. Okay, everybody? No confusion about this? Then another important point of difference between these conditions is chemosis and proptosis. Chemosis and proptosis is marked in CST, whereas it is mild to moderate in cases of orbital apex syndrome. Also, guys, remember another important point of difference, that there is edema in mastoid region. Edema in mastoid region present, cavernous sinus thrombosis, absent, orbital apex syndrome. And lastly, everybody, systemic signs such as fever, etc. are abrupt onset and severe in cases of the cavernous sinus thrombosis, whereas they have a slow onset and mild in cases of orbital apex syndrome. These are certain other differences, but usually you won't need to look at these other differences. All your questions you will be able to solve from this only. If you remember this, 346, 346, V1, V1. Okay, but second nerve is affected in orbital apex syndrome and the sequential ophthalmoplegia is there with sixth nerve first involvement in cavernous sinus thrombosis. These are the two important inflammatory causes of a case of proptosis. Okay, everybody? Now, There is another condition that you need to know in a little detail related to orbit, related to proptosis. Orbital cellulitis. Orbital cellulitis usually occurs as an extension from paranasal sinuses. So usually you will see that the child or the adult, usually in child, has ethmoidal sinusitis, which leads to orbital cellulitis, right? Then please remember, this is usually unilateral. It can affect all the orbital contents. That means it can affect all the nerves, second nerve, third nerve, fourth nerve, sixth nerve. Yes. So because 3, 4 and 6 are affected, there is complete ophthalmoplegia. Because second nerve is affected, the vision can be lost. But V1 is not affected. So because ophthalmic nerve is not affected, there will be no loss of corneal sensations. So this is a small purview from my side, guys, on proptosis. A very important but a very easy condition for answering questions. Now, to complete our orbit, everybody, there are a lot of questions which are asked on orbit related most common. So they will ask you what is the most common malignancy in adults, in children, orbital, blah, blah, blah. For that, you can see the list on your screen. Okay, everybody. So there are 10 most commons listed on your screen. Please just see that and learn that straight questions on most commons. No confusion, guys? Done? Okay. Now, there is another topic which is, you can say, kind of a medicine topic. But because it takes into account the eye, so a lot of students think it is an ophthalmology topic. What is that, everybody? That is a very easy topic, a topic which all of us have read in our final year, guys, in medicine. Thyroid associated ophthalmopathy. I will be simply going in terms of the easy MCQs that are asked on this, though very rare, but they are asked. Okay, everybody? Thyroid associated ophthalmopathy, or as some people like to call it, Graves' ophthalmopathy. This is the most common cause of proptosis, unilateral and bilateral both, in adults. Even though it is termed Graves' ophthalmopathy, we tend to think that it will only occur in cases of hyperthyroidism, but that is not the case. It can occur in patients who are hyperthyroid, euthyroid, or even hypothyroid. Obviously, it is most common with hyperthyroid, but it can occur even in euthyroid or hypothyroid patients. Now, everybody, if I talk about the important signs, there is a whole list of names, everybody. Not going into that, just the important signs. Number 1, what is the earliest signs seen in cases of thyroid associated ophthalmopathy? A lot of us think Dalrymple, a lot of us think Van Graaff. Both of them are wrong. The earliest sign is Gold-Zier's sign. Gold-Zier's sign is basically conjunctival congestion, or what I can call as redness. That is the earliest sign. Now, if I ask you the second sign, where I ask you what is the most common sign, you understand the difference? Earliest sign, most common sign. So the most common sign, everybody, is Dalrymple sign. Now, what is Dalrymple sign? We should know this because this is the most common sign, everybody. This, everybody. What is this, everybody? What is this, everybody? Upper eyelid retraction. Okay? Due to the sympathetic overstimulation, everybody, there is upper eyelid retraction. The upper eyelid will go up. Dalrymple sign. Then the second most common sign is proptosis. The second most common sign is proptosis, the topic that we are discussing in orbit here, everybody. Yes? Then another important sign which we all know the name of is von Graffe sign, which is popularly lid lag. What is the meaning of lid lag? That is all you can understand, everybody. Lid lag. When we look down, look at me, everybody. When I look down, my eyeballs go down, even my eyelid goes down. But in this case, because I have lid retraction, when I will look down, now think that I have bilateral thyroid associated ophthalmopathy. So when I will look down, only my eyes go down, my eyelids don't go down completely. So what I am saying? I am saying that my eyelid movement is lagging behind my eyeball movement. Eyeball go down, eyelid don't go down. Okay, everybody? So lid lag. Eyeballs go down. Eyelids do not go down. I hope this explanation is good enough for von Graffe sign. Then we have another sign, everybody, which is called as Cockers sign or Kocher's sign. What is this, everybody? Staring appearance. Because of the lid retraction, it looks as if the patient is staring at you. Yes? Another sign that you need to remember, you can remember, is Stellwag's sign. Stellwag's sign is reduced frequency of blinking. Number 7, everybody. Due to edema and fibrosis of extraocular muscles. See, at last, what is getting affected? Extraocular muscles. There is edema first, and then when later chronic stages, it leads to fibrosis. What occurs, everybody? Extraocular muscles are not able to act. So we say this fibrosis is restricting the movement. So we call it restrictive myopathy. Or if you can correlate with squint, everybody, it becomes a case of restrictive squint. Yes? So a restrictive myopathy or restrictive squint occurs. The questions that the examiners ask you is, what is the earliest muscle affected? So the earliest muscle affected, somehow it has been made into a controversy. There is no controversy. The answer is inferior rectus. Yes? Now, because the earliest muscle affected is inferior rectus, what is the earliest action affected? So understand, guys, we are talking about restrictive myopathy. Inferior rectus is fibrosed earliest. That means inferior rectus cannot act. It is permanently contracted. Fibrosis means contraction. Because inferior rectus is permanently contracted, it cannot relax. When a muscle cannot relax, its antagonist cannot contract. Are you getting what I am saying? Inferior rectus cannot relax, so superior rectus cannot contract. Because superior rectus cannot contract, the earliest action affected is elevation. The same fundamental we have used in Brown superior syndrome in squint, everybody. Yes, I hope you are able to understand this. I hope you are able to remember this. Nothing more in terms of ophthalmology for thyroid associated ophthalmopathy. This is all about orbit from my side, a single simple topic, that is proptosis, certain conditions and certain questions on it.